Welcome to the Dr. Izzy's Medical Podcast channel.
Porphyria cutanea tarda. Porphyria cutanea tarda is the most common subtype of porphyria. The disease is named because it is a porphyria that often presents with skin manifestations later in life. The disorder results from low levels of the enzyme responsible for the fifth step in heme production. Heme is a vital molecule for all of the body's organs. It is a component of hemoglobin, the molecule that carries oxygen in the blood. Hepatoerythropoietic porphyria has been described as a homozygous form of Porphyria cutanea tarda, although it can also be caused if two different mutations occur at the same locus. Signs and symptoms. Porphyria cutanea tarda is recognized as the most prevalent subtype of porphyritic diseases. The disease is characterized by onycholysis and blistering of the skin in areas that receive higher levels of exposure to sunlight. The primary cause of this disorder is a deficiency of uroporphyrinogen decarboxylase, a cytosolic enzyme that is a step in the enzymatic pathway that leads to the synthesis of heme. While a deficiency in this enzyme is the direct cause leading to this disorder, there are a number of both genetic and environmental risk factors that are associated with Porphyria cutanea tarda. Typically, patients who are ultimately diagnosed with Porphyria cutanea tarda first seek treatment following the development of photosensitivities in the form of blisters and erosions on commonly exposed areas of the skin. This is usually observed in the face, hands, forearms, and lower legs. It heals slowly and with scarring. Though blisters are the most common skin manifestations of Porphyria cutanea tarda, other skin manifestations like hyperpigmentation and hypertrichosis also occur. Porphyria cutanea tarda is a chronic condition, with external symptoms often subsiding and recurring as a result of a number of factors. In addition to the symptomatic manifestation of the disease in the skin, chronic liver problems are extremely common in patients with the sporadic form of Porphyria cutanea tarda. These include hepatic fibrosis, cirrhosis, and inflammation. However, liver problems are less common in patients with the inherited form of the disease. Additionally, patients will often void a wine-red color urine with an increased concentration of uroporphyrin 1 due to their enzymatic deficiency. Vitamin, mineral, and enzyme deficiencies. Certain vitamin and minerals deficiencies are commonly found in people with Porphyria cutanea tarda. The most frequently cited deficiencies are those of beta-carotene, retinol, vitamin A and vitamin C. Beta-carotene is required to synthesize vitamin A and vitamin A is needed to synthesize retinol. A lack of retinol-binding protein is due to a lack of retinol which is required to trigger its production. The damaging effects of porphyrins interacting with iron, absorbing photons to then emit reactive oxygen species is the mechanism of action that results in the itchy, painful blisters that are common with Porphyria cutanea tarda. The reactive oxygen species that are formed interact with and exhaust the antioxidants in the skin, primarily those of beta-carotene, vitamin E, and vitamin C. Supplementation of these three vitamins has been shown to decrease these oxidative effects and potentially diminish the severity of blister formation. No single vitamin of these three will inhibit the damaging effects of oxidized porphyrins, specifically uroporphyrins and coproporphyrins, but all three working together synergistically are capable of neutralizing their damaging effects. Pathogenesis. Porphyria cutanea tarda is primarily caused by uroporphyrinogen decarboxylase deficiency. Uroporphyrinogen decarboxylase occurs in nature as a homotomer of two subunits. It participates in the fifth step in heme synthesis pathway, and is active in the cytosol. This enzymatic conversion results in coproporphyrinogen 3 as the primary product. This is accomplished by the clockwise removal of the 4 carboxyl groups present in the cyclic uroporphyrinogen 3 molecule. Therefore, a deficiency in this enzyme causes the aforementioned buildup of uroporphyrinogen and heptacarboxylic porphyrinogen, and to a lesser extent hexacarboxylic porphyrinogen, and pentacarboxylic porphyrinogen in the urine, which can be helpful in the diagnosis of this disorder. Diagnosis. While the most common symptom of Porphyria cutanea tarda is the appearance of skin lesions and blistering, their appearance does not single-handedly lead to a conclusive diagnosis. Laboratory testing will commonly reveal high levels of uroporphyrinogen in the urine, clinically referred to as uroporphyrinogenuria. Additionally, testing for common risk factors such as hepatitis C and hemochromatosis is strongly suggested, as their high prevalence in patients with Porphyria cutanea tarda may require additional treatment. If clinical appearance of Porphyria cutanea tarda is present, but laboratories are negative, one needs to seriously consider the diagnosis of pseudoporphyria. Treatment. Since Porphyria cutanea tarda is a chronic condition, a comprehensive management of the disease is the most effective means of treatment. Primarily, it is key that patients diagnosed with Porphyria cutanea tarda avoid alcohol consumption, iron supplements, excess exposure to sunlight, especially in the summer, as well as estrogen and chlorinated cyclic hydrocarbons, all of which can potentially exacerbate the disorder. Additionally, the management of excess iron can be achieved through phlebotomy, whereby blood is systematically drained from the patient. A borderline iron deficiency has been found to have a protective effect by limiting heme synthesis. In the absence of iron, which is to be incorporated in the porphyrin formed in the last step of the synthesis, the mRNA of erythroid 5-aminol volinate synthase is blocked by attachment of an iron-responsive element binding cytosolic protein, and transcription of this key enzyme is inhibited. Low doses of antimalarials can be used. Orally ingested chloroquine is completely absorbed in the gut and is preferentially concentrated in the liver, spleen, and kidneys. They work by removing excess porphyrins from the liver via increasing the excretion rate by forming a coordination complex with the iron center of the porphyrin as well as an intramolecular hydrogen bond between a propionate side chain of the porphyrin and the protonated quinuclidine nitrogen atom of either alkaloid. Due to the presence of the chlorine atom, the entire complex is more water-soluble, allowing the kidneys to preferentially remove it from the bloodstream and expel it through urination. Chloroquine treatment can induce porphyria attacks within the first couple of months of treatment due to the mass mobilization of porphyrins from the liver into the bloodstream. Complete remission can be seen within 6 to 12 months, as each dose of antimalarial can only remove a finite amount of porphyrins and there are generally decades of accumulation to be cleared. Originally, higher doses were used to treat the condition but are no longer recommended because of liver toxicity. Finally, due to the strong association between Porphyria cutanea tarda and hepatitis C, the treatment of hepatitis C is vital to the effective treatment of Porphyria cutanea tarda. Chloroquine, hydroxychloroquine, and venesection are typically employed in the management strategy.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.